Thanks, my dear brother, Dr. Ashraf, and I would like to thank the ESHRE for this sincere and great spreading of knowledge. And I would like to thank my dear brother and the dear Professor Hassan El-Maghrabi and his colleague. You can get this lecture and more than 400 lectures from my scientific page on the Facebook and also from the slide share for free download. Today I will try to discuss the update in adolescent polycystic ovary syndrome, and my objective is to give a very clear message how to diagnose and how to treat. I will address 5 items: definition, prevalence, diagnosis, evaluation, and treatment. Start what is meant by adolescent. According to the WHO, adolescent are the young people between the ages of 10 and 19 years. And what is the definition of adolescent polycystic ovary syndrome? Thanks to the American Academy of Pediatricians, in a very few words, defined adolescent polycystic ovary syndrome. It is unexplained, persistent, hyperandrogenic anovulation. Unexplained, persistent, hyperandrogenic anovulation. The prevalence of adolescent polycystic ovary syndrome from 2% to 15%, depending on the criteria used for diagnosis and the ethnicity. The prevalence is increasing nowadays due to the prevalence of a childhood obesity. But we have risk factors: the premature puberty, that's to say the appearance of the pubic hair before the age of 8 years, obesity, family history, and ethnicity. It is more common in African American. The course of adolescent polycystic ovary syndrome may be progressive, leading to the full-blown picture of the adult polycystic ovary syndrome. But please keep in mind, this is a contradictory and do not agree for this. The risk factors for progress of adolescent to adult polycystic ovary syndrome are persistent irregular cycle 6 years after menarche, persistent anovulatory cycles 3 years after menarche, and increased body mass index. How to diagnose? It was discussed how to diagnose the adult polycystic ovary syndrome, but the criteria for diagnosis of adolescent is quite different and should be specific and should be very strict. And we will base on the last guidelines of the ESHRE in 2018. We should have regular menstrual cycles plus hyperandrogenism and or hyperandrogenemia. The definition of each one is strict, and we will try to see what is the definition of each criteria. For the irregular menstrual cycle, we should know the time of the menarche. And in the first year after menarche, any irregularity of cycle is normal. But after 1 year, if we have amenorrhea for 3 months, it is an irregular menstrual cycle. Between after 1 year to 3 years, if the menstrual cycle is than 21 days or more than 45 days, it is a regular menstrual cycle. After 3 years, if the menstrual cycle less than 21 or more than 35 days, it is a regular menstrual cycle. And if the number of cycles per year is less than 8, it is a regular menstrual cycle. Also, primary amenorrhea is a criteria for diagnosis. and it is defined if there is no menstruation after the age of 15, or if there is no menstruation more than 3 years post-celarchy. That's to say, no menstruation 3 years after the development of the breast. It is called primary amenorrhea. The second criteria, which is hyperandrogenism, and please, isolated hirsutism is not a diagnostic criteria. Isolated acne is not a diagnostic criteria. Isolated alopecia is not a diagnostic criteria. But moderate to severe acne should be considered. And severe or progressive hirsutism should be considered. As mentioned before, we will depend on the modified Ferryman-Galloway score, and it was described by Dr. Sharif, and we should put in mind the variation of the cutoff levels according to the ethnicity. And to if we for the Caucasian, if it is more than 8 and it is mild, from 8 to 15, and if it is more than 15, it is moderate. But it is also, we should consider the perception of the female is more important than the severity. For the alopecia, the androgenic alopecia is classified into type 1 and type 2 and type 3. The third criteria is hyperandrogenemia, and the definition is very important, as mentioned by Professor Norman. And the hyperandrogenemia of benefit if the clinical hyperandrogenism is unclear. We should not use, and we should use the high quality assay. The high quality assay is not available in our lab. And the high quality assay, like the liquid chromatography, and what is available is the direct assay, like the radiometric or the enzyme linked assay. And according to the guidelines, should not be used because the sensitivity is poor, the accuracy is poor, and the precision is poor. So what we will use to diagnose hyperandrogenemia? Also for the DHEAS and androstenedione of limited role in diagnosis of hyperandrogenemia of polycystic ovary syndrome. We should depend on the free androgen index, and we should use the upper limit of the reference ranges. If our patient is using oral or the hormonal contraception, it should be stopped for 3 months. And the free androgen index is calculated by multiplying the total testosterone by 100 and dividing on the 6 hormone binding globulin, and we should use the upper limit of reference ranges. We should not use the ultrasound criteria in the adolescent polycystic ovary syndrome before 8 years of menarche. Why? Because of the high incidence of the multifollicular ovary in this life stage. But we can use the ovarian volume in the adolescent according to the Pediatric Society guidelines, but they put a higher cutoff level. They put 12 milli for the ovarian volume to be a diagnostic criteria for adolescent polycystic ovary syndrome. As regards the AMH, should not be used because there is no well-defined cutoff. Some considering it 4.5, other 6.1, and other 7.2. We should not consider the insulin resistance or the compensatory hyperinsulinemia or the obesity as a diagnostic criteria for adolescent polycystic ovary syndrome. But there is a category. It is called at risk for adolescent polycystic ovary syndrome. And it is defined if only we have a regular cycle or only we have hyperandrogenism. What we will do in this condition? Ultrasound is not indicated. What is indicated is to give a symptomatic treatment. And what is recommended is regular re-evaluation. How? To do menstrual cycle re-evaluation after 3 years of menarche. Menstrual cycle re-evaluation after 3 years of post-menarche. And to do ultrasonographic evaluation after 8 years of post-menarche. The first point to be addressed, we discussed the definition, we discussed the prevalence, and we discussed the criteria for diagnosis. After that, we should evaluate our patient. We should evaluate the cutaneous manifestation, the terminal hair growth, the acne, alopecia. All of this indicates hyperandrogenism. And also the acanthosis nigricans and the skin tags, which indicate insulin resistance. We should evaluate if the patient is obese or not by determining the body mass index and measuring the waist circumference. We should screen the patient for depression. And if there is a depression, we should refer her for psychotherapist. We should screen our patient for sleep disordered breathing and obstructive sleep apnea. And if it is present, we should refer her for respiratory specialist. We should screen our patient for type 2 diabetes mellitus because they are at high risk of such abnormality by asking for the oral glucose tolerance test or the hemoglobin A1C if the oral glucose tolerance test is unable or unwilling to complete the oral glucose tolerance test. We should evaluate the risk of cardiovascular disease if there is a family history of she is smoking or hypertensive or hyperlipidemia. And lastly, we should screen for subclinical hypothyroidism. The last point to be addressed, how to treat adolescent PCOS syndrome. First, what is our objective? Our objective is symptomatic and also is prophylactic. We want to restore the body weight. We want to regulate the cycle. We want to reduce the signs of hyperandrogenism. And our objective also to prevent the long-term health hazards, infertility, metabolic syndrome, obesity, diabetes, and heart disease. So we defined what's called at risk. At risk should be treated. That's to say, we should treat the acne, the obesity, hirsutism, and irregular menses. The first line treatment is the lifestyle therapy. And the lifestyle therapy, let us start with the overweight or the obese. What we will do for them as a lifestyle therapy. Weight loss 5% will decrease the testosterone 20% and will resume the ovulation in 50%. And will depend on restriction of the calories because there is no evidence that one type of diet is superior. Also, the anti-obesity medication, the orlistat, can be considered with lifestyle, and we should consider the cost, the contraindication, the side effect, and availability. Also, the lifestyle includes exercise, and it was found that exercise will improve the weight loss and reduce the cardiovascular factors and the diabetes risk. And it's recommended, according to the ESHRE, to have 3 times per week muscle and bone strengthening exercise. Also, in the lifestyle, as we mentioned, it should be the first line treatment. Our girl should avoid alcohol, avoid smoking, and avoid psychological stressor. This was as regards the overweight and obese. What is about the normal weight adolescent PCOS? We should prevent any gain in weight. And we should ask her to monitor her weight and to increase the physical activity, because increasing the physical activity is effective in reducing the development of metabolic syndrome. Are you going to ask the normal weight girl to decrease her weight? No. According to the randomized controlled studies, this is not supported, and not ask her to reduce her weight, but only to maintain her weight and don't increase her weight. The second line of treatment after the lifestyle is the first line pharmacological therapy. The first line pharmacological therapy is combined oral contraceptive alone, and it should be considered in adolescent with a clear diagnosis of polycystic ovary syndrome, and also for at risk for adolescent polycystic ovary syndrome. But before prescribing the oral contraceptive pills, we should put in consideration the WHO contraindications of the combined oral contraceptive pills. And we should assess, as we mentioned, if the patient is obese or not, because this will determine our method of contraception. If the body mass index is less than 35, any type of combined oral contraceptive pills can be used. But if the body mass index is more than 35 kilogram per meter square, we should give combined oral contraceptive pills with caution. But if there is a morbid obesity, the body mass index is more than 40 kilogram per meter square, it is not recommended to use the combined oral contraceptive pills. May one ask, in this condition, if contraception is required? What is the method of contraception? The progestogen only methods is recommended in this condition with morbid obesity, that's to say with a body mass index more than 40 kilogram per meter square. What is about the type? No combined oral contraceptive preparation is superior, and it's recommended to use the lowest effective estrogen dose. And it was found that 20 or 30 microgram ethinyl estradiol or equivalent. As regards the risk of the deep vein thrombosis, the combined oral contraceptive pills containing levonorgestrel, norethistierone, and norgestimate are associated with the lowest risk of deep vein thrombosis. Just an important hint about the 35 microgram ethinyl estradiol plus cypritrone acetate. It should not be the first line of treatment of polycystic ovary syndrome, because there is a higher risk of DVT, and only it should be considered if we are treating moderate to severe hirsutism or acne. The most androgenic progestogen is the levonorgestrel and the norethistierone, and the low androgenicity is the norgestimate and the desogestrel, and the progestogen with anti-androgenic activity are dysprainone, cypritrone acetate, and dienogest. The second line pharmacological therapy is a combination of combined oral contraceptive pills and metformin, and this should be considered in management of metabolic features, and also where the combined oral contraceptive pills and the lifestyle doesn't achieve our goals. It should be considered in adolescent polycystic ovary syndrome with a body mass index more than 25 kilogram per meter square. The second line pharmacological is a combination of oral contraceptive pills and anti-androgen, and it can be considered after 6 months of cosmetic treatment and combined oral contraceptive pills if we didn't get appropriate results. And also it should be considered with androgenic alopecia. Anti-androgen reduces the androgen excess features more than the metformin monotherapy. And the most commonly used is spironolactone. And we should lay stress, when you are using anti-androgen, you should guarantee contraception in this condition. The third, second-line pharmacological treatment of adolescent polycystic syndrome is the metformin, and it should be considered in adolescent with clear diagnosis of polycystic syndrome and also of at risk of adolescent polycystic syndrome. Metformin is most useful with body mass index more than 25 kg per meter square, or in the high risk ethnic group, as we mentioned, the African American. We just to hint about is metformin is a weight losing drug? According to the randomized controlled studies, no. Metformin doesn't promote weight loss in obese adolescent polycystic syndrome. And when it is used in overweight or obese, it has a beneficial effect. What can we use it in non-obese? Yes, in non-obese with hyperinsulinemia, metformin will improve the ovulation and the testosterone level. What is about inositol? It should be considered experimental according to the guidelines, and we are in need of more research to include it in the treatment of adolescent polycystic syndrome. A very important question is for how long we will use combined oral contraceptive pills or metformin. It is not yet been determined, but it is advised until the patient is gynecologically mature, that's to say 5 years after menarche, or there is a substantial amount of loss of weight. So the duration of use of the metformin or combined oral contraceptive pills 5 years after menarche, or when we get a substantial decrease in weight. To come to the last slide, we are in the era of the evidence-based medicine, and as we mentioned, we have this is the lines of the treatment of the adolescent polycystic syndrome, the lifestyle, the combined oral contraceptive pills, the metformin, and the anti-androgen. And there is strong evidence of the lifestyle in the menstrual dysfunction, in obesity, in glucose intolerance and diabetes. And there is a good or strong evidence for combined oral contraceptive pills for menstrual dysfunction, hirsutism, acne, hyperandrogenemia. And there is strong evidence for metformin in the insulin and the glucose intolerance and diabetes mellitus. And there is a good or strong evidence for the anti-androgen in hirsutism, acne, and hyperandrogenemia. To come to the conclusion, for diagnosis of adolescent polycystic syndrome, we should diagnose it early and accurately. And the criteria for diagnosis differ from those used in adult polycystic syndrome. In 2 words, irregular menstrual cycle plus moderate to severe hyperandrogenism and or hyperandrogenemia. Of course, after exclusion of the other causes of hyperandrogenism and menstrual irregularity. We should evaluate the metabolic status, the cardiovascular risk, the psychological status, dermatological manifestation, and subclinical hypothyroidism. For treatment, it should be individualized, depending on the age, depending on the symptoms, depending on the risk factors and the choice of our patient. The first line is lifestyle modification. The first line pharmacological is combined oral contraceptive pills. The second line pharmacological treatment is a combination of pills plus metformin, combination of pills and anti-androgen or metformin. شكرا لحضراتكم.